Okay, wonderful. Well, thanks for being able to stay with us a bit longer. We are in the last session of the day, but I hope you had a nice opportunity to enjoy the lunch. Sorry it was more rushed than we would have liked. We still tried to give you the 60 minutes, almost. But I also hope, importantly, with most meetings like this, that you were able to take advantage of it to connect or reconnect with colleagues and already think about all the nice ways that we can continue to work together. So having said that, you know who I am. I'm not going to introduce myself, but I am really, really delighted to be introducing and moderating our final discussion, our session 4 on opening policy pathways. And we were a bit cut off at the end of the last session, so we do want to encourage you, if you have outstanding questions or feedback on what you heard about the guidelines, and guidelines, I mean really plural, the various fantastic resources that exist. I think a clear segue is that we have all those resources, and I was really grateful that our colleagues from WHO and from ECDC put the QR codes, so that is information that you should have been able to access pretty quickly. You might be wondering, right, River EU guidelines, where do I find those? They look really interesting. They're coming, and they'll be up soon on the River EU webpage. Of course, then you say, but the project website will die. It will, but we're not going to let it die right away. It will be up for a few years, and in the meantime, we've also been establishing a relationship with TechNet 21, which you may know, it's an online platform that was initially established by WHO and UNICEF all the way back in 1989 that hosts all kinds of fantastic resources for health, for vaccination really, and for practitioners working in this area. So we'll be setting up a dedicated page for all the different educational resources coming from the project that you can find there. We're always happy to see how we can cross-promote and cross-link with others and make sure that we make this information as widely as accessible as possible. As I was discussing with Andrea, I think knowing what's out there is 50% of the battle sometimes. So anyway, all of that to say, great. We have these fantastic tools and resources, and I think that really helps us establish that we can confidently build an evidence base. We do know what the challenges are. We can find the data. We have resources to then do something about it. So where does that take us? Well, that takes us to the point of policy, right? Because research and practice don't become policy on their own. There need to be entry points. There needs to be the right process or the right moment, the right institutional home. I think coming back to the Slido that started session 3, I saw sustainability in giant. They weren't red flashing letters, but they might as well have been, because I think we can't also forget about the topic of resources. And I think right now we have to admit that Europe talks about vaccine equity as if it's a priority, but it funds vaccine equity like an afterthought, right? There aren't new projects coming in this field, and it's something that I think all of us would love to see, but that is not a reason for despair. That's a reason for us to then think creatively together. How do we keep this on the agenda? How do we connect what we're doing, what we've learned, to other important priorities, be it competitiveness, be it the climate? Those are all important things. So how do we make sure that this work doesn't get lost? And so to discuss all of those things here in this final session, I'm really delighted to have 4 people who sit at different points within the European and national policy landscape. And I want to just discuss in this last 45 minutes that we have, where are some of the doors or even the policy windows that we might be able to push on, and how do we open them? So let me quickly introduce each of you. And again, thanks so much for being here. It's a pleasure. First, I'll start with Dr. Katarzyna Lewtak, or Kasia. And she's an assistant professor at the Department of Social Medicine and Public Health at the Medical University of Warsaw, and a researcher at the Department of Population Health Monitoring and Analysis at the National Institute of Public Health, which is where we've gotten to know her as a member of EuroHealthNet. And her research addresses populations and vulnerable situations such as refugees, migrants, and individuals experiencing homelessness, with a particular focus on barriers to healthcare access. So really, thanks so much for being with us. I will also go ahead and introduce, just to my right, my left, I should say, Fatima. So Fatima is a public health professional with over 12 years of experience working on immunization systems and child health across Europe, Central Asia, and other regions. And you are serving as a health specialist within UNICEF's Center for Excellence and the Global Program Division, where you provide technical guidance to governments and country offices and lead partnerships with EU, Gavi, and WHO. not mistaken. I know there's been a lot of changes, so maybe your agenda says something else, and if it does, we apologize for the oversight. Brett, we had the opportunity to introduce you in the last panel. We're not going to test you so much on TIP now. You're ready for something else. And finally, Marijn. Marijn Stok is a behavioral scientist whose research focuses on understanding vaccination decisions and developing interventions that support vaccination uptake. So you're a program leader of the SocioVax research program at the Dutch National Institute for Public Health and the Environment, and we're really delighted to have you with us as well. So I will stop talking. You've heard enough from me, and I'd like to already hand the floor to Brett, but let me lay the ground before I give you the question. I promised we won't talk about TIP and tailoring health programs. We're going to talk about the European Immunization Agenda 2030, which is another document, and I think much more than a document, a strategy and plan that you should hopefully all be familiar with. And what we really loved when this agenda came out is how central the focus on equity is. There's a big focus on equity in immunization and tailoring local solutions as core pillars. As you've heard this morning, that's a main focus of the work we've been doing too. But the latest technical progress report that was published in late 2025 paints a somewhat concerning picture. The current pace of progress is not enough to meet the 2026 milestones, and let alone the 2030 targets, and immunity gaps are widening. I mean, I think we all see the news. We know immunity gaps, unfortunately, are growing, and measles is back in countries where it had been eliminated. At the same time, to add to this, let's say this is internal to immunization itself, we also see that the political priorities are changing and shifting. And the immunization agenda sat within the first European program of work, but within the second European program of work, we see different priorities, different named priorities, let's say. Climate change, healthy aging, health security, tackling NCDs. These are, of course, all legitimate and very urgent concerns, and they can all have a connection to immunization. But now, being realistic, they are all competing for attention and resources. So, Brett, with that landscape, could you tell us a bit about what let's say, the operational status of the Immunization Agenda 2030 within the new program of work, let's say new program of work, EPW, and how would we address equity within this landscape?
Sure. Yeah, it is concerning. Definitely, we do see immunity gaps widening. We see measles having a resurgence in many areas. We also see, unfortunately, also that only about half the countries in the region have engaged in addressing immunization inequities recently, and according to their reports to us as well. And what we see, why this matters so much is that despite the fact that some countries are reporting a decline in coverage overall, we're not seeing a general failure of immunization systems. What we're seeing is a failure to reach specific populations, specific communities consistently over a period of time, right? And that's what creates these immunity gaps. It's not just what happened this year, but it is actually something that has been going on and may be exacerbated by current conditions. And so it is important that we keep equity as the focus. With the new European program of work, the equity still remains a central component. It's just being operationalized a bit differently. Under EPW1, equity within it was very explicit, especially immunization equity due to the European Immunization Agenda 2030. So we saw a sort of a flagship initiative. We saw it being highly visible. It was definitely prioritized, and this was all very positive. Under EPW2, we are seeing a shift. This is due to broader system-wide priorities. So again, the priorities have shifted now to things like health security, resilience, life course health, NCDs, aging, climate, etc. Equity runs through all of these priority areas. It's no longer vertically positioned as it was under EPW1, but it is not less present. Unfortunately, it is less explicit. The equity commitments are still there, but they are embedded across these different priorities. And in practice, equity is being delivered through primary healthcare strengthening, through service delivery improvements, outbreak preparedness, life course vaccination strategies, et cetera. And part of this is, as we know, those of us who have cared about immunization inequities, we know that inequities in immunization often aren't found alone, but that they often exist alongside other inequities, right? So in a way, it makes more sense to embed equity in these other areas rather than keep it as a separate standalone topic. But does this mean that it is potentially at risk of being neglected further because it is less explicit? I would say yes, definitely at risk. With risk comes opportunity as well, in the sense that if it's at risk of being diluted, but actually now that it's embedded in more locations, there may be new partnerships, new opportunities to collaborate with others in these other priority areas that maybe weren't there before, that can provide us an opportunity to move forward with addressing inequities more broadly while championing immunization equity as well. So I think that's important to remember, that while we think about the risk of it being diluted, we don't think of the risks being alone, but also that there is an opportunity here as well. I think where perhaps where we need to move is particularly in this area of health security. This priority area for us is where immunization lies in general, and it is an opportunity for us to actually move immunization equity into a more central role within this broader term of health security, focusing so much on prevention rather than only on emergency preparedness. This gives us an opportunity to show that equity is not just a moral obligation, but actually also a very practical and essential approach to ensuring health security more broadly. It is these pockets of under-immunized populations that can create greater risk for populations as a whole. And so it's not just about fairness, but it's actually about the front line of outbreak prevention. Which again ties to the broader priority of things like health security. So as I said before, yes, it's at risk of not, it's no longer as explicitly mentioned, but in some ways it is, as it's embedded, it's more tightly tied to broader, more pressing issues that unfortunately it won't naturally happen by itself. We need to advocate for it. We need to show its importance. We need to make those ties to these broader areas much more explicit, I think, in order to gather the political will and support around the topic. But I certainly think there's definitely an opportunity to do that. So, yeah.
Thanks a lot. And I have many different thoughts and places that I might want to follow up, but to privilege, again, that all of you have the opportunity to speak now, I think there's a great hook that connects to what we'd like to hear from you, Fatima, and that's the point of prevention as a pragmatic solution, something that we can look at and we say, yeah, but this just makes sense. Come on. During the launch of the WHO UNICEF estimates of national immunization coverage in 2024, you called for urgent action, including prioritized funding and investment in immunization programs and health systems. And to help make this case, UNICEF has recently published evidence. You have a report, Costs of Inaction, to reach zero-dose and under-vaccinated children in Europe and Central Asia, of which you were a co-author. And it quantifies not just the health impact, but also the educational, social, and economic implications of failing to reach these children. So I think very much about this question of making new allies and partnerships and seeing this embedded across a broader approach. But I just want to mention a few of the numbers because they're really striking, and I think we can think about how we might want to apply these in our own work when we think about making a case to, let's say, a Ministry of Finance, how they would invest more in health and in prevention. So you say, for instance, that $3.4 billion in projected losses are foreseen in just 4 countries in Eastern Europe if nothing changes. So I guess the direct and indirect losses related to under-vaccination or zero-dose children. returns on investment of up to $76 per dollar invested when coverage reaches 95%. And it also does mention that reaching the so-called hard-to-reach children, so these exact populations that we're talking about today in many cases, it can represent up to 66% of the total per-dose vaccination costs, so it may be more expensive, indeed, to reach these children. But at the same time, the returns on the investment can be disproportionately large. So this framing, I would think, would land very well right now if we look at the EU context and we think about the competitiveness compass or these bigger economic messages that we have. Having said that, I think if we take Western Europe as a frame, and I know UNICEF, of course, is a much broader region, but sitting here in Brussels, if we imagine we're taking Western Europe as a frame, the European Union doesn't really think of itself as low coverage. Right? So how would we make this argument around the cost of inaction, how would we make that land in a context of Western Europe? And I think this also connects to a later question I'll ask on toolkits and things that you're developing with the European Union. But basically, how do you translate this and make it connect with them?
Thank you so much, Alison. And it's such a pleasure to be here with all the colleagues, and especially I was really inspired with all the presentations from the people from the field. So I come from the field. I worked with the Roma population. I worked setting up the Roma Health Mediators work. I have worked with Ukrainian refugees 2 weeks after the Ukrainian war started. I was on the border with Moldova, setting up the vaccination programs for the Ukrainian refugees coming in. And in the Balkans, I worked with the refugees and migrants that were on the Balkan route to the European Union, trying to cross into the European Union. So I really, first of all, I want to say I admire you. I know how much it takes because you're often fighting between, the high-level decisions and trying to make it very practical at the field level. So thank you for that. Yes, and what I've also seen in the field is that often we have wonderful interventions that really work. We see they're working, they're adjusted to the context. But once the project is out, the intervention stops, and you've seen it as much as I have. And then we lose all this wonderful work, and it's not enough to document it because we don't know who will take it on. So that's where we started talking about more economic argument. So what we did is this cost of inaction report was actually launched in December 2025, and it turns the public health argument, which all of us here, that's what we do. We do public health argument. Vaccination saves lives, right? It turned that into an economic argument. So this economic argument is actually from vaccination saves lives to not vaccinating is really expensive for the countries. You're losing a lot, even if we're talking about very small numbers. This is the key. So what we found is that within the cost of inaction is that around 60% of the costs that countries were incurring were actually coming from the productivity loss. So we're looking at parents who cannot go to work, at a boy, girl who cannot go to school. They're quarantined because there is a measles case and they're not vaccinated. So all of these losses actually amount to 60% of the total loss to the countries. Only 10% is showing up to be as a healthcare cost. Okay? So we cannot make health arguments. We can make a health argument, but we cannot make it alone. Of course, we're sensitive. We think children need to be vaccinated, and we know that they need to be vaccinated. But we also need to present it differently to the governments that are thinking about the money. So Alison brought up a very good point. What we also found, so the results cannot be applied to the European Union, clearly, because you're in a different level. The countries that we were working in, have their upper middle income or middle income countries. And here we're talking about high income countries. However, what we did find is that, as Alison said, it was 2 to 3 times more expensive to reach an underserved child. This is a fact. So the economics shows it. It is more expensive because there are multiple deprivations, as you said, multiple deprivations that children are facing. It's harder to find them. That's why we need these targeted approaches that can actually reach these children. It's not just about doing the routine program as we've used to do it. And this is what we need to pass on to the policymakers, to the people who are deciding on the budgets. This is a fact. So while the marginal cost of reaching an underserved child is higher, so are the benefits. That's what we are seeing as we did the cost of inaction analysis. So once we have this data, the argument basically, for example, for the outreach, because we were talking about outreach today, the argument that it's too expensive disappears, because then you see the benefits that you're getting out of not getting an outbreak in these communities and trying to treat it and losing all of this additional, resources. So this is one point that I wanted to bring really home. I think it's important, and we can share and you can look at the cost of inaction as well in these countries. The second point that I wanted to bring up is this point that we hear often, right? The EU average for vaccination is excellent, and you're doing a great job. I mean, that's a fact. It's some of the highest averages in the world. But there is an uncomfortable truth behind it. When we dig deeper, as you have done through the River EU, we see that there's a lot of inequality. So while, some countries might perceive it as a criticism, the message that I really want to pass on is not that we're criticizing. We're just saying that, yes, you have generally strong systems that can do better, that should be reaching all the children, because you're still losing funds, you're still losing money in the long run. And even if we look at the absolute numbers, because we were talking about measles, so 35,000 cases of measles in 2024 in European Union. That's a lot. One case to treat, on average, costs about $1,500, just in the healthcare costs, nothing else. We have 146,000 zero-dose children, so children who have not received their vaccination. That's a lot. For me, for a strong system that the European Union has, it is a large number. And then across the EU, the data shows that there's 1.1 million girls, 15-year-olds, that are not vaccinated against HPV. And we know that HPV protects from cancer. So we know it's evident. So the story when we're talking about it, it's not these national numbers, and it's not the 96% aggregates that you see. It's the subnational data, it's the community level data. It is exactly what you're doing here. And that's why I'm saying you've done a wonderful job, and you've taken away from some of these numbers exactly through this work. And the third point is that, and we discussed it extensively, I'm not going to go too much into it, but under-vaccination in European Union is often framed as a vaccine hesitancy issue and misinformation issue. And I hear it all the time. I worked in the region for many years now. I worked in the field. I worked at the regional level, global level. Often I hear it's just misinformation. And this is really problematic, because once we start focusing on misinformation and the vaccine hesitancy, we stop talking about the structural problems that we have, and we have structural problems. They need to be addressed, because if we don't address them, we're not reaching those children, and it's the duty and economic benefit, if you wish, to reach those children. So I think when we talk about how does it land in the European context, I think what we need to start doing is moving away from the vaccine hesitancy issue and really focusing on structural barriers. And cost of inaction is doing exactly that. So it looks at the vaccine hesitancy, because realistically it's a part of a problem. I mean, we cannot deny it, but it looks more as the structural barriers that need to be addressed and need to be funded in order to reach all the children. And finally, we were talking about European Agenda 2030. European Union has signed up for many different commitments. Just recently, all the member states agreed to adopt a child and adolescent health strategy, which we work together with WHO on, and immunization is part of it. So each one of your member states have committed to implementing child and adolescent health strategy with the immunization component. We talked a lot about the financing piece of it. So the documents are there. We have it. Basically, the countries now need to come in and put the funding where all of these commitments are. We haven't yet done the cost of inaction analysis in the European Union, and I will talk a little bit more about that later. But basically, we do have a project with DG Sante that is now in progress, and we're taking all the wonderful evidence that you have created, all the programmatic level interventions that you have done such a great job on, and seeing what are the policy barriers that are preventing it to be sustainable. So one of the things that we're looking at is this cost of inaction tool, basically where we will develop like the immunization equity toolkit. Within that, there will be a cost of inaction tool that can be applied to European Union countries and specific on different contexts. And this will be launched in summer 2026. So I will stop here. Thank you.
Wow. So yes, as we might say where I come from, I was preaching to the choir. So I really fully endorse all those statements around. I've always thought we work a lot at EuroHealthNet on non-communicable diseases, and we always talk about the idea of lifestyle creep, that there are a lot of structural barriers that we face around healthy diet, around physical activity, and so on. But it's very convenient to be able to say, yeah, well, you should eat healthier and you should take your bike to work. And I feel that vaccine hesitancy somehow is that same equivalent of the lifestyle creep within communicable diseases, that it's very convenient and comfortable to say, but they don't want to be vaccinated. Well, let's take a look at ourselves. Anyway, we could go on about that all afternoon. I think absolutely very curious to hear more about the cost of inaction tool, and it sounds like that's actually very soon, summer 2026. But it also sets us up nicely what you were saying about the cost of inaction for what we would like to discuss with you, Marijn. And I think, when we've been doing some work and thinking about this, of course we need to tailor programs, but to what end? If I say, but yes, we expect in every health center in a small town in the Netherlands that they're going to have an interpreter for 20 languages. I mean, of course, that's not very realistic. I think we have to ask ourselves, we understand that it's effective to tailor our programs, but they're also very resource intensive, and there's a tension there. We have to acknowledge that tension, and I think, again, that comes through in this work. So at some point, the system has to really take a decision about what it can realistically sustain. And with the work that you're doing with Sociovax in the Netherlands, Marijn, we understand that you're generating evidence on which populations are being missed by the vaccination program and why. And I think it would be very nice if you could tell us more about how that evidence can help us resolve this tension around where we need to be investing our resources and what truly makes the program equitable for all.
Yes, now it's on. Yes, I'm happy to try and say something about that. Could I get the slide that I had prepared? Yeah, because I want to take a little bit of a meta approach or meta perspective on policy making, if you will. This is a picture from the multiple streams framework by Kingdon. And I always find it extremely helpful when thinking about how policy decisions are made or not made. So I want to take you through that a little bit, and hopefully in doing so answer the questions that were posed to me. So what Kingdon says is that political action, policy action, happens when three different streams come together. And these are three streams that meander, wind, turn in complex ways, in somewhat unpredictable ways, and very importantly, in separate ways. So they are not connected to each other. And the first stream there is the problem stream. And what Kingdon stipulates here is that a bad situation, having low vaccination uptake, for example, is not necessarily a policy problem. For a bad situation to be perceived as a policy problem, as something that politics has to address, there has to be something happening. We have to be able to frame it in a way that policy can address it. And even if that is happening, policy problems can be framed in very different ways. So low vaccination uptake can be seen as a problem of bad individual parents who are making bad decisions. Low vaccination uptake could be used by anti-immigration rhetoric, harnessing it in a way to say it's the fault of people migrating across countries that we don't have our safe herd immunity anymore. The problem could also be framed as a structural barrier issue, which is what we, I think, all feel it is. So that's, I think, where the first part of our opportunity, but also obligation comes in, trying to make sure that the policy problem is framed in that way, as a problem not of individual parents. All parents, by and large, want to protect their children the best way they know how. If they think not vaccinating is the best way, that's a structural issue. That's a mistake from the system, not from these individual parents. So that's the first part where I think we can take action. I'm going to go into how to do that a little bit later. Then, if we are able to have that problem stream in the direction we want, it's a structural problem, a systemic problem that requires solutions at that level, well, then actually we have a lot of the work for the second stream, the policy solution stream, there already. Like the work from River EU. We know what is effective. We know that fine-meshed, diversified approaches are effective. And we can match that to the problem. And if we have those two together, then we are somewhere. But if you also look at the figure, matching the problem and the solution alone is not enough. Then we also need the political will. It has to be seen as a priority. Scalability is really, in the end, a priority issue. There is money. It's just a question of where do we put the money, like you also said, Alison. We frame it as a priority, but if we look at what is actually happening, it's at the bottom of a list of a lot of urgent topics, of course. And that's, I think, where we also have a lot of work to do and where we have to be strategic and where we have to work together. Because there are policy choices that we have to make. We cannot stress everything at once. We have to choose, maybe geographically. We have to choose maybe by community. We have to choose maybe by vaccination. Maybe by age group or whatever we together think is most important. And if all of us try to do this independently, it's lobbying in the end, this lobbying process, nothing is going to happen because we won't be able to generate enough force together to push that politics stream towards the problem and policy streams. So I think that's a big task for, well, I say us, but of course there are many more people involved, but as a collective, to make those decisions, to be very, it's also hard, of course, to say we're going to do this, but not that. But I think that's what we have to do together in order to get somewhere in the end. And then, in a smaller scale, that's what we are trying to do now within Sociovax in the Netherlands, taking the evidence from the country, from the different regions, from the health services who do a lot of good work on small-scale interventions, large interventions, huge multi-component interventions where we have no clue which component is actually the effective one, but taking all of that together and trying with the stakeholders, with people from the communities, to decide where is that priority. And then taking that back to our political people and trying to really have something happen.
Thank you very much, Marijn. And I think, indeed, I remember I was reading a book by Tom Frieden, actually the former CDC director in the US, and he talked about if you indeed scale too quickly, then you are more likely to fail. And once you've failed, then people say, oh yeah, but that didn't work. Let's forget about that and let's try something else. So indeed, I think smart scaling, targeted, strategic scaling makes a lot of sense. Thank you. And I do want to pick up, one of the problems that you mentioned, or something that might be perceived. I think the important thing is the perceived problem. You mentioned people migrating across different borders, people coming from other countries. And but the reason our herd immunity is impacted isn't us. It's the people who are coming, right? And I think that comes very nicely to what I would love to be able to discuss with you, Kasia. Last year, WHO Europe saw the highest number of measles cases in more than 25 years. And I know right now you are currently analyzing measles cases in Poland and looking at how outbreaks affected various communities, including Ukrainian refugees and Roma communities and the wider host population, or the wider population, which could be, of course, anyone. And I think it's important to mention that you are specifically challenging the assumption that migrants and refugees are responsible for driving those outbreaks. So could you tell us a bit more about what is driving some of this resurgence in measles in Poland, and what does it tell us about how we should design both the epidemiological response, but also the policy response?
Thank you, Alison. We analyzed in Poland, in National Institute of Public Health, measles surveillance data between 2022 and 2025 during the period following the outbreak of the war in Ukraine and the arrival of millions of Ukrainian citizens to Poland. We wanted to address questions that often appear in public debate. Are migrants and refugees driving outbreaks? And what are the public health implications of sudden large-scale influx of conflict-displaced populations for the host country? During the study period, Poland reported 454 measles cases. Almost 60% of them occurred in 2024 alone, reflecting the wider European picture when we observed the increase in measles cases. When we examined the Polish data more closely, we found that only 11% of measles cases involved individuals with a migration background, mainly Ukrainian citizens, and only 6 members of the Roma community. The remaining nearly 90% occurred in the Polish host population. This is an important finding because it challenges a simplified narrative that links measles resurgence mainly to migrants or populations in vulnerable situations, a perception that is partly driven by differences in vaccination coverage and different epidemiological situations in country of origin and host countries. But the real driver behind the increased measles cases in Poland, especially in 2024 and 2025, something that linked migrants, Roma community and host population was not nationality, not ethnicity, and not refugee status, but it was insufficient vaccination coverage. Among patients with known vaccination status, more than 60% were unvaccinated. It was about 69% among migrants, but also 65% among Polish citizens. And nearly in 1 in 5 cases in both groups, vaccination status remained unknown. Additionally, every 6th migrant and every 5th Polish citizens had received only 1 dose of the vaccine. We also identify almost 50 infants, around 1 in 10 cases, who were too young to be vaccinated. These children depend entirely on community protection. When population immunity declines, they become very exposed. Although children represent over half of the measles cases overall, among migrants they accounted for nearly 75% of infections, compared with around 50% in host population. That suggests that children are particularly exposed and vulnerable to health risk in situations of conflict displacement and lack of vaccination in either the country of origin as well as in host country creates an additional health risk for them. Among 6 Roma patients, all 3 children in this group were unvaccinated, including 1 because of age, and 2 adults has received only 1 vaccine dose, and 1 case had unknown vaccination status. So What is driving this immunity gap? First, we know that COVID-19 pandemic disrupted routine immunization services. Across the whole HWO European region, approximately 1.2 million children missed their measles vaccination between 2020 and 2022. The second one, we see the impact of vaccine hesitancy and misinformation, especially among young mothers from Ukraine. And third, the measles is a disease of a connected world. Rising global incidence combined with international travel and population mobility increase the risk of importation this disease and spread, particularly in the communities with insufficient vaccination coverage. And our study leads to one central conclusion. Measles resurgence in Poland is not primarily a migration issue. It is a consequence of accumulated immunity gaps across the whole society. So if the immunity gaps are the problem, then public health interventions to increase vaccination uptake must be the response.
Thank you so much, Kasia. And it's really powerful to, I mean, the numbers, I think they speak for themselves. So thanks a lot for sharing that really insightful research that you did with us. And it speaks very much to the conclusions coming back to Brett, which is actually where I want to go. And I'm conscious that officially we close in 5 minutes. I know we've gone a bit over time. There's no other meeting after us in this room. So I was taking the liberty to run a little bit over schedule, but I know maybe not all of you can stay much later. So we will try to be quite quick with the last round here, because then what we'd like to do is invite again our colleagues who started the morning, our community members, to come back and give their final reflections. But before we get there, one more round with all of you. I wish we would have scheduled till 5, because I could stay here and do this all day. But coming back to that conclusion, Kasia, that you gave us, that it's really an accumulation of these gaps over time. That fits very much what you were saying, Brett, that, you know, we have this accumulation of consistently missing people, and that's one of the things that the European Immunization Agenda is meant to address. What happens, you know, that's meant to run to 2030, running alongside EPW2, and I think, you know, very interesting to think about, indeed, where are those opportunities? It's a threat, but it's also an opportunity. After 2030, what's the vision for what comes next? Do you have any insights that you could share with us?
No.
Executive.
I don't have insights, because the discussions around what comes after EIA 2030 will happen later this year, and it is very much member state driven. So there will be contributions from them as to what the priorities will be in that, but it is forthcoming. But I would, just because you gave me the floor, like to stress what I would like to see in there in terms of not only immunization equity, but to Kasia's point, this issue around having the data to show what's really going on is super important, I think, and sometimes we don't talk enough about that, and inspired by my conversations at lunchtime as well with Colin about the data quality issues as well, that we talk about inequities, but it really needs to be data driven, and for things to be data driven, we need to have the data for it, and the data needs to be accurate. And so that is something that I think needs further attention, resources around, and understanding. From my own experience, I can say, and I'm really happy to have heard Kasia's example, that there are still many assumptions made about these communities, about their needs, but also about the vaccination status, the reasons for under-vaccination. And when we actually get down to the actual numbers, we can really find out that it's not necessarily either it's this problem or that problem, but it's actually, okay, the proportion of the problem is due to this reason, a greater portion is due to this other reason. And just like talking what Fatima said about so much emphasis around hesitancy, if we can actually do better at understanding what proportion of under-vaccinated people is really due to hesitancy, and then even taking it a step further, what is driving the hesitancy. Actually, a lot of times we find that it's a minority of cases that are due to simple motivation or concerns around the vaccines, and a greater portion are due to services that are not reaching those populations. And so strengthening our ability to have data to really know what's happening, be able to segment in a more precise manner, to be able to understand the needs and the barriers and who they're affecting, and what proportions of these communities are being affected by different barriers, I think is going to be very important if we're to move forward with more effective actions that can be, again, more precisely tailored to be more effective and to build more confidence in vaccines, but also probably more importantly is to improve access and create the environment for which people are vaccinated with a lot less barriers overall. So I would think that just more precisely than immunization equity, it is breaking down what equity is about and then strengthening those components, and one of which being strengthening our the data around this issue, and for us to be able to enact in a more, again, data-driven, data-informed way.
I think we'd sign up for that vision. That sounds great for a step forward. And I know that that's something that we are hoping to discuss a bit more, understanding sociovax, because there's a lot around data there. One last point I'm going to mention to all of you, because I think all of us being here together, that's one of the most important things. I mentioned the lunch, but it's just being together in this room, that we all share this this interest. And if there's one last thing that I forgot to mention it to you, Brett, but if you could say, along with this last intervention, is there something concrete you'd like to ask from the people in this room, something that you heard, or some follow-up, some opportunity, understanding that we're working in this constrained environment? What could we do together? So coming first, though, back to you, Fatima. You were talking let's say, giving a bit of a preview that you've got this very nice project that you're working on with Santé now. Does any of that have to do with collecting data, with the work that you'll do, or how will this project help us move forward on the questions around vaccine equity? What would you hope can shift with that work?
So this project with DG Santé is actually a child health project. So immunization is just one of the components that we're looking at. And the rest of it is mental health, promotion of like marketing to unhealthy foods to children, promotion of healthy lifestyles, protection from marketing, promotion of healthy lifestyles, early childhood development. So these are 5 components to the program. So it's basically to promote good physical and mental health and prevent health problems in children and adolescents through impactful actions across various settings, enhancing the understanding of how to improve children's health and how to address effectively the most pressing health challenges. So I'm reading the exact words from the project. And the steps that we're undertaking, we're first doing the needs and gaps assessment, mapping of good practices and policies, which is something that, honestly, we're not creating any new research, because there's so much out there in the European Union space that there's no need. We're basically taking in the research that was already done by, for example, River EU, and sort of working on that, what's already there. The project is more focused on the policy level interventions. So it's not what works programmatically, because we have that, we know. It is taking the programmatic level and trying to find policy levers that need to improve, that need to be, in place in order to sustain all those actions. So I was talking about the costing and funding and that as piece of sustainability, and that's exactly what we're looking at. So we're looking at interventions like that, and it is not focused so much on practitioners in the field. It is really to garner the political will, which I really liked from your policy level. So it is the third step to sort of complement the work that you have been doing to garner the political will through things like cost of inaction, or looking at the multi-sectorality piece. This is coming up through very strongly because we have health education here. This is something that needs to be improving, as well as the legal frameworks. So sort of that's where the whole discussion is going. And the underlying outcome of the whole project is to foster public dialogue on child health issues, including immunization. So the child is at the center of this, and we're trying to create conditions that would support the child, every child, and every underserved child in the European Union as well. So the evidence that you've created has been really helpful and really used well to move this to a policy level work. Yes, thank you.
Thanks a lot. That's, I think, I can speak for all the partners when I say that's really encouraging to hear. Thanks a lot. So I mentioned already that I would come back to the data point, and so many of the things that you said we would like to have to be able to segment and really disaggregate this data, and I know we're making these calls for broader health equity issues too, not only around vaccination. In the Netherlands, would you say that you have access to a lot of this data already, that you're able to use some of this through Sociovax? And Sociovax, of course, is nationally funded and nationally focused. What would it take if another country wanted to build something similar?
Can I have a slide again? Yeah. Because it will help explain faster in the end. But I can start already. So Sociovax, so we used the lovely THP approach to structure what we are trying to do. I can't move forward, so if you can just skip one ahead. Thank you. Because I'm part of Sociovax, which is the social scientific part of vaccination uptake in the Netherlands. But Sociovax is positioned within a much broader approach called, well, badly translated, moving forward with vaccination, where we have also DataVax, which is an excellent group of epidemiologists looking at actual vaccination uptake data in many different ways. So they are able to relate this to a large number of socio-demographic and socio-cultural variables. We know based like down to the streets what vaccination uptake is in neighborhoods, but we also know based on school denomination of the child what vaccination uptake is based on their parents' socioeconomic position. So we have a lot of data available. So that situation analysis, which is the first step, is really quite extensive, I would say. And then that comes to us, basically, to Sociovax, to understand the why, and also think about how can we approach maybe change, what would be necessary for that. But we are also directly connected to communication specialists in-house and to people working on professional development and continued education for the people in the field working with parents. Then we are also setting up a community of practice for the professionals to talk with each other, to exchange knowledge, to exchange experiences, to exchange best practices, because we see that interventions are tried out time and again in different places in the country, and then not even talking about what happens internationally. So you want to be able to build those bridges, you want to be able to connect and to make sure that we are building upon each other's work rather than reinventing that wheel time and again. And we have an advisory board of key community persons at the moment thinking along with the research part from start to finish, but hopefully the dream is to extend that both in the number of people in that advisory board, but also in where we ask for their advice and where they are part of the co-creation process, so to also include them in all the communication that is being prepared from our Public Health Institute to the public, and to make sure that they look in on the professional development efforts that we are developing. Again, that takes money, so that's where we are now in talking to our government, but this is there, and I would say that, well, it's far from perfect and we have a lot of room to grow, but I do think this is a structure that works really well in connecting the different players, in making sure that the relevant stakeholders can easily find each other, and to make sure that the data that is there is being interpreted properly and then being translated to proper interventions, which are also rolled out by the services that have to do, like the communication and the changes in education, for example, for professionals.
Thank you so much, Marijn, and it's really inspiring to see this nice practice. And I'm thinking that RIVM and actually National Institute of Public Health are working together in a working group on best practices within EuroHealthNet. And I'm thinking, that's very interesting. I don't know, what could be, the whole day has been about transferability. Is there something transferable from, resources depending, but it's really great to see that approach and how you're operationalizing it. So my last question is to Kasia, and again, I'm sorry we're a bit over time, so we will go to the panel after that, our final panel or close. But first, I do want to pick up a point that I think is really important in public health and something that we are all experiencing all the time. And it's this cycle of, I call it the cycle of crisis and neglect, right? When there's a public health crisis, what do? We throw money at the problem, right? We throw attention at the problem. And then it goes away and something else is the priority again. And I think, the work that you were doing in Poland, what you were studying, it was in reaction to a crisis. There was an outbreak of measles. But what would it take if we wanted to build some sort of responsiveness into the system before a crisis? What kinds of things can we do to help keep the attention on these issues before we face another outbreak? Not an easy question, I know.
Thank you. I think our experience from 2022 showed us that the ability of the health system to respond to changing health needs, for example, the health needs of conflict-displaced population, must be embedded within the healthcare system itself rather than being activated only during public health emergencies. This is very important both for healthcare professionals who are required to deliver healthcare in such situations, but also for the patients who are often trying to navigate in new reality, trying to find the solutions for their health problems. A proactive approach from the healthcare system perspective would mean a clear understanding of health needs, predefined scenarios and practical solutions, so that in public health emergency care can be delivered to those who need it, ensuring that no one is left behind. In the context of vaccination of conflict-displaced patients, this should include, for example, clear guidance to healthcare, prepared protocols for individual immunization schedules, as well as practical instruction for the healthcare workers, how to manage difficult situations and how to address barriers that migrants and refugees might face when assessing health services. But we know that guidelines alone are not enough. Implementation depends on the system capacity, and healthcare professionals can only fulfill their very important role effectively only when they are properly supported. For example, with access to interpreters, cultural mediators, materials for patient educations in different languages, and also sufficient time in consultations to address patients' questions and concerns. This also should be reinforced through continuous professional development and embedded early in pre- and postgraduate training for future healthcare workers, One example of this approach was, for example, introduced in 2023 at Medical University of Warsaw. It is an optional course on migration health for the medical students. And building on the lessons from 2022, we recognize that healthcare workers need not only clinical knowledge, but also practical tools to navigate vaccine hesitancy, complex patient pathways, and reality that could help them work with a diverse population and also delivering care in public health emergencies.
Thanks so much. That's a really inspiring example with the university and bringing it back. And I think it comes back to everything else that we've been talking about of how important it is to be able to get information out to people. And that includes, of course, our community members, but also the health professionals who work with them. And that was not data that you saw in the slides from Janine, but we do have data as well on how healthcare professionals reacted to the opportunity to also receive more information about how to work with the different communities. Okay, with this, I'm going to thank again our wonderful panel for your insights and your feedback. And I'd like to invite, I believe it will be Michael, who will also come up with our community members again from session 1. And just a final reflection from each of you as we close the day and as we, I guess, ceremoniously close our project.
I didn't quite realize I have the honor of the final session of the final closing. Here you go, of River EU, and of course, for me, it's quite emotional because it's been 5 years of incredible work, and often one of the main issues with these kind of projects is that there's a beginning, and we've talked about this a lot. And there's an end, and then all the benefits of the project disappear. But I'm actually quite hopeful that this is not the case, because there's been so much discussion and so much effort about ensuring that the legacy of River EU and the approaches, the methods that we've developed carry on, and particularly with the last session, talking a little bit about the policy landscape, I really see an important role for River EU as a piece of the puzzle of the broader policy landscape around immunization equity or health equity more generally across the European region, and that gives me a lot of hope. And hopefully, it was really important for us to have key players like ECDC, like WHO, like UNICEF in the room. To ensure that the River EU and particularly the guidance that is coming out of River EU is visible and is clearly part of the solution. So we started the day with voices from the field, and we went all the way up to regional policy, and now we're back with voices from the field, and I think it's very, very suitable. What I would like to do is I would like to share, I just had 3 important thoughts throughout the day that I want to share with you, particularly for those of us who are public health practitioners, whether it's at the policy level, whether it's the local level, the national level. I think often we talk about concepts like co-creation, like community engagement, but how often do we actually get out of our offices in universities, in public health agencies, in ministries of health to go and not just meet the community, but actually engage in meaningful, equal relationships to come up with the right solutions. And I think River EU is a rare example of this, of taking these concepts and putting them into practice. So my first lesson, my first takeaway is actually, let's get out of our offices and let's do this in a meaningful and real way. And the second one is, again, we as public health professionals often make assumptions about the communities that we're supposedly tasked with improving health. We make assumptions about who they are. We make assumptions about what will work, what will not work. But actually, it really, I think, one of the key things with River EU is it really shows that you need to go very, very local and to the point where, you know, talking about a migrant community or even talking about a Moroccan community, it doesn't always make a lot of sense, because from one place to another, it will mean different things. And also, individuals are complex. They're defined by so many things. So without actually leaving our assumptions aside and going and understanding from the community what are the concerns, what are the barriers, then we're not really going to succeed. And the third one is, again, for all of us who are tasked with improving the health of the community, improving immunization. There's no need to start from scratch. There's so much evidence that exists, and what River EU has done is providing the tools to take this evidence and then making it something relevant and useful for the particular communities that we work with. So it's there, and please use it, because I think, and I hope I speak on behalf of the entire consortium. We want nothing more than all our hard work being used, being put to practice, and impacting on the communities. And I'm really, really pleased, and I think it was a brilliant move to invite members or actors within some of the communities that we've worked with here, you know, to the heart of policy making in the European region. So I'd like to actually give the final words to our panel. This is a rare opportunity to speak to, you know, the European Commission, to ministries of health, to universities. So if you had one piece of advice to give us in terms of how to best work with the community to improve health outcomes and to improve immunization outcomes, what would it be? So I'm going to start to my left, and then we'll go to everyone.
Actually, I would tell that listening them. Listen what they want, what they ask. Like really, like listening, I mean like not only like someone is talking and you have to listen. No, asking also. Like why you come, what you need, why you need. When you go deeper, when you're talking to the person deeper, he would believe you. And I think this is the main thing that I want to tell. Like listening and talking, communication is the key word for me.
Projekt River končí, je to úžasný projekt, ale som vďačný, že som sa mohol toho zúčastniť a fakt je to najlepšie, čo mohlo byť. A takisto by som chcel povedať, že aj keď končí, my sme v tom rozbehnutom vlaku. My nekončíme, lebo my sme v tej lokalite a my s tými ľuďmi žijeme. Preto by som chcel, že by sa tá veková hranica posunula ďalej, aby fakt mali možnosť aj tí ľudia, ktorí sú starší. Lebo teraz je možnosť vo veku 12 do 14 rokov, že by sa zaočkovali tí deti. Ale fakt, tí rodičia rozhodujú za nich.
First of all, I would like to say that I'm very grateful to be the part of this wonderful project who brought also to our communities a huge change. But it's not end for our communities, because it will continue even the River EU project. It's at this end. The one advice which I would like to take opportunity now to tell all policy and decision maker is, please, let's do our best to increase the window and create the window of the opportunity to have a free vaccination also later in life, because in the age group from 12 to 14, or let's say 15, there are parents who are making decisions for these children. And it would be really great to create the opportunity for catch-up vaccination, that also children who were not vaccinated in this age group and this age window because parents were not properly informed or were not privileged to do this decision, could have this opportunity to be freely vaccinated. And František explained it very simply. We know that it is good and it's helpful, so let's do our best to bring it to as wide group of people as possible.
Taktiež chcem podotknúť zo skúsenosti, že prišli za nami tí ľudia, staršia veková hranica, že prečo sa oni nemôžu zaočkovať. Že tí rodičia niekedy majú veľmi málo informácie. Tá staršia veková hranica si vie naštudovať, či to na Facebooku, na tých sieťach internetových, a už sami sa vedia rozhodnúť. Sami si to nevedia dovoliť, lebo je to veľmi finančne náročné. Preto by som chcel poprosiť, že ak by sa dalo na tých vyšších miestach, aby mohli umožniť tým ľuďom, že by mohli mať lepšie zdravotné, by som povedal, prístup, áno.
So there are a lot of people who came to us with this question, why we do not have to have a free vaccination. We would like to have some. We have now some information. We reach the information through the social media, through the Facebook. We know it is good, but we can't afford it. Please help us to do so.
A na záver by som chcel podotknúť, že tento projekt, ako som spomenul už na začiatku, máme zahrnuté v našej organizácii Zdravé regióny, že je to súčasťou toho nášho programu, kde tí naši asistenti pracujú na tom, aby mali dostupné informácie, aby mohli mať tie zdravotné poznatky.
So even when the river project is at the end, now it is under the organization structure of the healthy communities and healthy regions. So it is really included in the basic daily workload of each health mediator. So it will continue even when the river will be finished. Thank you.
I find it hard to summarize because I think so many great things have been mentioned already. I think what we've seen is that underserved communities are not always simply misinformed or simply hard to reach, but with the systems that we have now, they are hard to reach because they weren't designed with these people in mind. And we see many different communities that I think, when it comes down to the core, are dealing with the same barriers. So I think what would be helpful is to create a system that would target these barriers, and I think then a lot of issues would already be targeted, but also to look at, in each community, they've already created their own system. They already have created their own way of gathering or communicating with each other and use these systems. You don't need to start completely from scratch. We're not asking you to create a bunch of different systems for each community, but just use what already exists in the community, build onto that, and try to target the main barriers that each community is facing. And I think then we'll together be able to make a huge difference in reducing health inequalities. Thank you.
And with everything said already, I would like to add that River EU, I feel that has already grown very strong roots, as being here with just a school, nothing more, and given so much time to express what we feel and what we see in the field. Sometimes we take for granted the way of life we have, and maybe assumptions or data is not the strongest point. I would like to add, without being an expert on that, why did you choose vaccines and you haven't chosen mouth health or feet health or whatever? I mean, that is all by itself a self-explanatory, very strong argument to the decision makers to say that what we're doing, as I feel like to say here, is that you're trying to design a healthier future and thus a happier future for people who really look for a new, for opportunities. They haven't flee their countries for nothing. So they expect something from Europe. And Europe expects something from them because, of course, that's the way of our life is. I don't expect for my children to say, I'm not going to vaccinate my grandchildren. For me, it's unacceptable. So what I really feel at the moment is that what we're doing, we're just a school, I'm not doing anything. What River Youth has tried to do is to give a new perspective of what field work means. Thank you.
Thank you so much for your time and being with us. And with this, I close River Youth.
Just to come in, as we would say in Spanish, and be in aguas fiestas, so the rain on the party, the couple of administrative details, there were some sign-in sheets at the entryway in case you didn't sign in. Could you please sign the sign-in sheet? And we have these lovely badges in line with trying to be green and circular economy. If you could please recycle your badge into a box at the front. But if you have any questions, we're here and happy to answer. And thanks again for your time and your interest.
Thank you.